thank you very much for coming. How many of you have been to previous ones of our conferences? Okay, good, some returnees. And I need to let you know that the restrooms are just right out there in the hallway, and there's an exit there, 2 exits, I feel like a flight attendant, and one out the door. And this is very good attendance, so thank you very much. It's a beautiful day, and we're very happy to be here. And we have Dr. Colin Ross to speak for us today, and he will be speaking several times, and we're very glad to have him here. He's come from Dallas, and he will be going back tonight, I believe. And he has 1 patent and 1 pending, and he's been in China about 7 times and is doing research over there. He's written 23 books, 7 of which are on dissociation and trauma. And we also want to thank, this year the City of Davis again donated us the space. And Connie Valentine, I don't know if Connie is here at the moment, she might be off making coffees, but she organized this conference for the first 16 years. And she has retired and stepped down from that right now, but when she comes in sometime we'll give her a hand. But Andrea Ransdell, who's been involved for many years, took over this year, and this is Andrea writing notes over there, and she did it this year for the first time. Give her a hand. And we're also very happy that for this year, for the first time, we have interpreters for the deaf and hard of hearing from NorCal Services. We have Christy O'Neill and Ramona Baird, and they'll be switching off about every 20 minutes so that we can have interpretive services for the deaf and hard of hearing. So we're very excited about that. And Rhonda Bagos will be here from, I think it's Minnesota, where she's coming from, and she's going back, I believe, to sing tonight there. So she will be here about noon, and Andrea's husband and daughter are picking them up from the airport. So we have all kinds of people working on things here. So I want to introduce Dr. Ross, and he will begin speaking for you when we have to trade microphones here.
I'm Colin Ross. I'm a psychiatrist, but please don't hold it against me. Any psychiatrists in the audience? Well, thank you for attending. Therapists? Psychiatrists are badly outnumbered. And non-mental health professional, consumer, members of the general population. Okay, good. So that gives me a little feel for that. So I was born in Canada. Let's see, that'd be over 20 years ago now. Went to medical school in Canada, did my psychiatry training. So medical school was 77 to 81, psychiatry was 81 to 85. Then I was an academic university teaching hospital-based psychiatrist, 85 to 91. And then 91 I moved to Dallas, which was a very noticeable improvement in the weather. Because there's some days where, I moved from Winnipeg, there's some days where in January, February, where the high in Dallas and the low in Winnipeg are over 100 degrees apart. That explains why I moved to Texas. Since 91, I've been director of a trauma program. 91 to 97, it was a charter. 97, I moved to Timberlawn. And 98, started a program in Michigan, and then inherited a program in LA in 2000, all in hospitals owned by the same parent corporation. And I do 3 groups a week in Dallas, where I live, and 1 a week by video conference in Grand Rapids, Michigan, 1 a week in Torrance, California. And then I visit once a month to Michigan, do consults and groups for a couple days, and slightly less frequently I go out to LA. So I actually have hands-on like involvement clinically, and it's almost 20 years now I've been doing that in Texas. So that's kind of the work environment that I've learned things in. General inpatient with trauma people flowing in, and specialty trauma programs. And what I'm going to do today is kind of talk about what I've learned and the way that I do this work, which is based on a model called the trauma model. So I'm going to, first of all, start off with the dissociative structural model, which is kind of a way of thinking that integrates together all the different diagnoses, symptoms, problems that people have. Then I'm going to talk about trauma model therapy, which is my method of therapy, explain some of the details of that. And then after lunch, I'll talk about eating disorders and sexual abuse to illustrate the role of trauma and mental health in a little bit more detail. And then Rhonda will talk for a while, and then after the break in the afternoon, it'll be more case examples, discussion, questions, and kind of more free-form talking about some of the techniques and strategies in a little bit more detail. And then we'll wrap up about 9 p.m.
All by yourself.
Yeah. Oh, that's interesting. Slides aren't moving forward for some reason. Always a new problem in life.
There you go.
It worked.
Okay. It was just kind of frozen up there. Okay, so you should have copies of all the slides. So this slide is just contact information, web page, email. So I see the core problem in the mental health field as what I call the problem of comorbidity. Intellectually, research-wise, and practically, clinically speaking. Comorbidity usually is the different diagnoses that go along with your main diagnosis. So it's comorbidity, meaning illness. So there's morbidity and mortality in medicine. But I've expanded the definition of comorbidity a little bit to mean not just all the diagnoses, but all the symptoms, addictions, defenses, behaviors that go along with what is supposed to be your main diagnosis. But what's your main diagnosis to me is completely arbitrary. So it's a whole melting pot mess of different symptoms, diagnoses, addictions, self-defeating behaviors. That's comorbidity. So why is that an intellectual, conceptual problem? Well, I could talk about that for a couple hours, but real capsule summary. The whole mental health field is set up so that we have different groups of disorders. We've got mood disorders, anxiety disorders, substance abuse disorders, and these are supposed to be separate categories and separate things. If you look at the basic epidemiology, which is studying how common things are in the general population, there's a bunch of studies that show how many people will develop schizophrenia in their lives, how many bipolar, how many panic disorder. And if you look at the basic frequencies of these disorders, you can figure out how many people should have 2 or 3 or 4 or 5 at the same time if they're actually independent disorders. So just using sort of rough numbers, schizophrenia is about 1% of the population, which is 0.01. Panic disorder, about 2% of the population, say. So the percentage of people who should have both of those disorders, if they're actually separate independent things, is just the random chance of 0.01 times 0.02. But as I'll show you just in a second, the average person coming into one of my trauma programs meets criteria for 15 different diagnoses on a standardized structured interview. And that interview doesn't even ask about all the diagnoses in the DSM. So the question then becomes, if the average person's got 15 different diagnoses, how does that fit with the basic arithmetic? And the basic arithmetic is, for 15 different diagnoses, you go 0.01 times 0.02 times 0.1 times 0.03 times 0.01, and you end up with over 10 zeros after the decimal place. That's the number of people who should have that many different disorders if they're actually independent, randomly occurring things. So that's less than one person on the planet. So something's wrong with the arithmetic. It just, this model of separate independent diseases just does not work. And in medical school, you're taught a whole bunch of stuff, but basically you're taught how to be a doctor and what doctors do. So what doctors do is they make diagnoses. And there's 2 rules that I think govern this. One is the single disease model. So by and large, day in and day out, working basis, pediatrician, family doctor, internist, you're trying to make the diagnosis. If you go to the ICU, then people got a whole bunch of different diagnoses going on at once. But most of the time, day in and day out, you're focused on the diagnosis. So there's a single disease model, and then there's diagnosis determines treatment. So if you're a family doctor, it's really handy if you can tell the difference between an ear infection, a pregnancy, and a sprained ankle. Because we actually have different treatments for those three things. So in general medicine, this actually more or less works. We actually have differentiated, distinct, separate treatments for separate diagnoses, and we know at least something about what's going on physically down at the cell level and so on. So that's the single disease model, diagnosis determines treatment. And of course, there are people who've got multiple problems, but this is just the day in, day out workload of medicine. Then you go into psychiatry, you're still an MD, you're still a doctor. The people you work with are called patients. If they're really sick, they go to a place called a hospital. You write prescriptions, you order blood tests, and so you follow this medical model. So you make the diagnosis. This person has schizophrenia, this person has bipolar, this person has an eating disorder, and then you have treatments that are supposed to match these different diagnoses. And that's the way things are supposed to work. But the problem is, you can't find somebody on an inpatient unit. I mean, there's rare exceptions, but basically you can't find somebody who just has a disorder. Because even the trauma program, it's 15 different disorders average over a lifetime, of which 5, 6, 7, 8 are active currently. In a general adult inpatient unit, it's the same picture, just scaled down a little. So maybe there's 5, 6, 7, 8 diagnoses lifetime. But still, you can't find somebody who just meets criteria for one DSM disorder. So you can't have diagnosis determines treatment, because you'd have to have 6 different treatment plans going on all at the same time. And you only have an inpatient length of stay of 7 days, maybe, for typical inpatient. So you can't have 7 different treatment plans for 7 disorders in 7 days. It's just ridiculous. So what actually happens is you kind of pick out what's the main diagnosis and mostly kind of ignore the rest. And maybe we'll deal with that later. But if somebody comes into the trauma program and we just make one diagnosis and we treat that, and they actually have 10, 15, we're treating under 10% of their problems. So just making the diagnosis and ignoring the rest doesn't make any sense. So then the other alternative would be, in our trauma program, basically all 3 programs, it's about an average of 12 days length of stay. And it's about half Medicare, half managed care patients. And then about half the people go to the day program for a couple of weeks. That's kind of how long people are around. So if somebody's an inpatient for 12 days and they've got 15 diagnoses, what we could do is just decide which are the 3 least important, and we could treat the depression for 1 day, treat the eating disorder for 1 day, treat the substance abuse for 1 day. So obviously that's absurd. So what we need is a way of having an integrated, unified treatment plan that takes all the different problems and diagnoses into account, but isn't like a discombobulated mishmash of all these different treatment plans. And to get there, we go through the dissociative structural model, and then in terms of what we actually do, trauma model therapy. So this is the problem of comorbidity. And this is just illustrating, it's a study I did back in the 90s, which I'm actually repeating now. And it's a standardized structured interview called the SCID, which is used in lots of different research. And this is the number, there's 103 people. This is the number of people who meet 4 different diagnoses, 6, 7, 9, 10, on axis 1, which is one set of the disorders in the DSM. And the average is 7 point something. And this is axis 2, where the personality disorders are, and the average is about 4 point something. So 4 point something and 7 point something add up to 12. And then the SCID doesn't diagnose a sleep disorder, psychosexual disorder, or dissociative disorder, which most people have all 3. So that's how I get to 15. And this is typical of people in mental hospitals, people in jails, battered spouse shelters, homeless people, adolescent sexual offender treatment programs, residential treatment centers for substance abuse. Everywhere you go in the mental health field, if you're dealing with people who've got pretty serious mental health problems and addictions, you got lots of comorbidity. And when I was in Canada, I actually participated in some drug studies run by drug companies and published a number of papers as a result. And so I learned how the recruitment process works. So I did one study on generalized anxiety disorder, which is just having general severe anxiety all the time. And in 6 months, from academic department of psychiatry and an academic department of family medicine, I was unable to recruit a single person. Because to get into the study, you have to have just generalized anxiety disorder. You can't also have substance abuse or depression. You can't have panic attacks. So there's a whole bunch of mental health problems you're not allowed to have. So it's just fairly pure, clean, generalized anxiety disorder. Couldn't find a single case in 6 months because everybody's got too much comorbidity. So when you do these kind of drug studies, you actually advertise on the radio and the newspaper. And out in the world, not seeking treatment, not seeing psychiatry, there actually are people who have just one or maybe two disorders, but not people in the mental health system who are serious consumers. So how to blend this all together? Well, the way I do it is the dissociative structural model, which is a structural, not an etiological model. Etiology means the cause. One of the things you learn in medical school is if somebody comes in and says, "Doc, my elbow's killing me," you kind of look at the elbow and then you say back to the person, "It seems like you may have an acute osteoarthritic problem of some type." And the patient goes, "Wow, that guy really knows what he's talking about." But all you did was turn it into fancy language saying, "It sounds like your elbow's killing you." So we don't like to say cause, we like to say etiology. And what that means is, this is about the structure in the person's mind, not the cause of the structure. So you could have a dissociative structure in place, potentially because of genetic problem, some birth injury, some brain infection, an explosive device going off in Iraq, a million possible causes. At a practical level, I'm talking mostly about trauma, but we're setting cause aside for a second and just looking at the structure. And if you go around in the mental health field, there's literally dozens of schools of thought in the mental health field, which kind of boil down to the biological school and the psychological school. And within the psychological school, there's all these different models, vocabularies, theories. And they all have something in common. They all talk about people who have mental health problems. The opposite being the ideal, perfectly healthy individual, which would be everybody in this room. So the ideal, perfectly healthy person, who actually doesn't exist, is fully integrated. That is, they have a very fluid, flexible identity and persona. They can take on different social roles. They don't always act the same in every situation, but they always experience everything as, "This is me doing this." They take full ownership for everything they think, say, feel, and do. They take full responsibility for the impact of all their behaviors on other people. Okay, so I haven't met anybody exactly like that. But that's the ideal. So it's a matter of you're either closer or you're further away. The opposite is somebody, so that's a person who's integrated. Fluid, flexible, balanced, integrated, unified self. The opposite is somebody whose psyche is all divided into compartments, disconnected compartments, and depending on which compartment's up and running, they don't take ownership for this, they don't feel it, they are in denial about it, it's like it never happened. So there's a failure of information flow from one compartment to the other. And the information can be thoughts, feelings, behaviors, perceptions, and so on. And these different compartments have different names depending on which literature you're in. So there's actually a book called Ego State Therapy where these different compartments are called ego states. In some Freudian writing, they might be called part selves or part object identifications. So, and there's a whole bunch of theory that goes along with this different vocabulary. If you went to MIT, Massachusetts Institute of Technology, and you were talking to guys who are like hardcore behavioral science research guys, they wouldn't use any of that Freudian language, because they're scientists. So they would call the compartments modules, and they would talk about the mind, brain being modular. That is, it's not just one thing, it's got subsystems. So memory, for instance, is divided into, there's different vocabulary for it. It's kind of like conscious, unconscious. Implicit, explicit, declarative, procedural, there's different vocabulary. But memory is composed of two dominant subsystems, and then there's even subsystems within that. So it's not just one thing, it's a bunch of compartments that interact with each other. And if you're healthy, these compartments interact in a nice, flexible, fluid fashion. If the diagnosis is multiple personality disorder, now called dissociative identity disorder, then these compartments are called alter personalities or identity states. So there's all these different names. And the thing that makes dissociative identity disorder different is that these compartments are very elaborated and personified. So they have a different name, age, gender, hair color. So there's different people inside. Now there's not literally different people inside. There's actually only one person who's fragmented into these compartments, and the compartments are all crystallized and elaborated. But subjectively, it's as if, experientially for the person, it's as if there's other people living inside you. And there's switching. So you're talking to grown-up Mary, and all of a sudden little Susie comes out. She's 6-year-old, different voice, different memories, different attitude. So that's the switching. And then the little person goes back inside, and the adult doesn't even remember that conversation you just had in the therapy session. So there's full switching and full amnesia. And the compartments are very elaborated up to separate. That's DID. So in this model, what we do is we take DID and we scale it down, 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 down to like half or 2/3. So we have these compartments. They're pretty separate. They're not fully elaborated alter personalities, but they're way off of a fluid integrated self. And in therapy, I often explain this in terms of the inner child way of talking, the inner child model. So, and I'll ask somebody, have you ever done inner child work? And they may or may not have, and I'll say, okay, well, here's what I'm talking about. The inner child basically applies to everybody on the planet. And it's on a spectrum from this end to this end. At this end, the inner child is just a metaphor, figure of speech, way of talking. It's just a way that therapists like to talk about some of your unresolved feelings from childhood. That's all, nothing more to it. At this end, the inner child is DID, dissociative identity disorder, where the child actually comes out and talks, has all these different thoughts, feelings, memories, goes back inside. The adult doesn't even remember the conversation. That's a lot more than just a metaphor. There's an actual structure there that's very elaborated. And then there's all degrees of gray in between. So one person goes, inner child, that's stupid. I'm not going to do that. Forget it. Okay. Next person goes, okay, there's no inner child, but I see what you mean about your feelings. Yeah, that makes sense. Next person goes, yeah, I actually feel like there is a child in there, but it's just kind of a feeling. The next person is, yeah, there's a child in there, and yeah, she's very separate, and I can actually kind of visualize her. And she's 6 years old, and she's wearing ragged clothes and very scared and huddling in the corner. And the next person can visualize the child and hear her crying and talks internally to the child. But the child never, there's no switching, so there's no DID. The inner child just stays inside. Next person, the inner child, might actually sort of take control, but the adult isn't gone. They're just kind of a little bit in the back seat, depersonalized watching. And they're behaving in a very childish way, and they feel kind of little, but they're not gone. And then we have DID where the adult's actually gone. So there's all these degrees. So that's what I'm talking about here. And so the dissociative structural model is written about in great detail in this book called The Haunted Self. But it actually goes back to 1880. A bunch of people who are writing about trauma in the 19th century. And the guys who wrote this book have developed this model and made a bunch of predictions and elaborated on it, but it's been in the field for over 100 years. So in the dissociative structural model, there's this basic configuration. You've got the adult self, and you've got the wounded inner child. And in their vocabulary, it's the apparently normal personality, which is the adult self, and it's the emotional personality, which is the wounded child. And so that's the core structure. You've got these two compartments. And then you've got intrusions and withdrawals. Instead of a full switch, you have feelings, thoughts, perceptions, memories, impulses intrude up from the wounded child into the executive self. Or the adult self pushes that stuff back down and doesn't want to feel it, know it, or deal with it. So it's the dissociated structure with intrusions and withdrawals. And it's the adult persona and the wounded child. That's the basic configuration here. And the visual on this is the adult person is living up there in the light of day, and the child is in that underground compartment down there in the psyche. So it turns out that having dissociative identity disorder is the extreme version of a dissociated structure. But it's not just human beings who have dissociative identity disorder. Dissociative identity disorder is a way that systems are organized. So after thorough research, I have some very bad news for you. You live in a country called the United States of America. Yeah, this is the Canadian perspective. So it's the United States of America, but it's not actually the integrated States of America. And then we have this entity called the federal government, which suffers from dissociative identity disorder. Because the federal government obviously doesn't work as an integrated, fluid, flexible, healthy, adaptive system. There's all these subsystems that are in conflict with each other, don't share information, work at cross purposes. So having a dissociative structure really is a general system concept. It's a way that systems are fragmented, fractured, and work at cross purposes and have internal conflict. Another example of a dissociated structure is the DSM-4. And the reason I know it has a dissociative structure is my name's actually in the back of the book because I was on the Dissociative Disorders Committee, so I've actually been inside this process. And you've got this manual and you've got the mood disorder section, the anxiety section, the substance abuse section, the eating disorder section. And each of these sections has a committee. And the guys on this committee all know each other, they go to the same conferences, they publish in the same journals, so they're the mood disorder club. And the guys in the mood disorder club don't really know or talk that much to the guys in the eating disorder club. Because they have separate journals, separate conferences,
Exactly.
separate books. And that's the way the whole system is organized. These groups really don't communicate. And when you look in the DSM, the way the rules for eating disorders get set up can be quite different from the rules for mood disorder. So the structure and logic and rules can be different. And you can be in this section, and it'll say, if you want to make this diagnosis, you have to rule out this diagnosis over here. But when you go to this section, to make this diagnosis over here, it doesn't mention that diagnosis over there at all. So there's not a fluid, organized cross-communication between all these alter personalities equals sections of the DSM. But so I'm going to walk through this fragmented collection of different diagnoses and try and make an argument that they're all actually just variations on the same theme. And since they're all variations on the same theme, when you have all these different diagnoses at the same time, according to the rules of the DSM, you don't actually need 10, 15 different treatment plans. You just need one integrated treatment plan. So how does the dissociative structural model apply to dissociative identity disorder? Well, if it doesn't, then we're in big trouble and might as well stop talking about it. So I'm just going to assume that dissociative identity disorder must be based on dissociation. So I'm going to run through all these different disorders and make this argument that they're all variations on theme. Theme being trauma and dissociation. So from my perspective, dissociation is not just this little, obscure sub-area over on the fringe of psychiatry, which is how it's generally viewed. Trauma and dissociation is a core theme that's everywhere in the field. to varying degrees. In the DSM, psychiatrists have spare time on their hands because they don't have to do surgery in the middle of the night and stuff and get a good night's sleep. So, since you have spare time, you got to tinker with this DSM and have a new edition every once in a while. And it's kind of fun to change the names of disorders once in a while. So we used to have manic depressive illness, now we have bipolar mood disorder, because we cured all the affective disorders overnight. And all of a sudden we had an epidemic of mood disorders. So we change the names once in a while. And there's various rationales and reasons for that. So if we could change post-traumatic stress disorder, PTSD, to bipolar trauma disorder. I don't actually want to do that. But why am I talking about this? Because bipolar mood disorder, manic depressive, is where you go up into mania and down into depression. So there's two poles, so it's bipolar. So if you have bipolar mood disorder, you both go up into mania and down into depression. If you have unipolar mood disorder, you just go down into depression. Of course, you could appear to have unipolar depression because you haven't gone into a manic episode yet, but you might next year. So, but it's bipolar up and down. So in PTSD, likewise, there's two poles. There's an up pole, which is, and these are all the criteria that are in the literature, that are in the DSM. Nobody's debating these are the criteria. So the up pole is all the hyperalertness, startle, flashback type symptoms. And this is clearly the adrenaline overdrive, sympathetic nervous system. And it's the fight or flight response. So this is basic mammalian threat response systems. All mammals are designed this way. Some mammals specialize in flight, like the gazelle. Some in fight, like the grizzly. Human beings, sometimes specialize in one or the other, but have the capacity to do both. Then there's the down pole of PTSD, which are also in the DSM criteria, in the literature everywhere, and that's the numbing, denial, avoidance, shutdown kind of symptoms. And here we're talking, of course the whole thing's like mega complicated because the brain's beyond comprehension, but basically we're talking about the parasympathetic nervous system being more dominant.